Management of postpartum hemorrhage. Clinical presentation. Recognition. Resuscitation. Definitive treatment. Postpartum hemorrhage, or PPH, is the leading cause of maternal death worldwide. It is bleeding of 500 milliliters or more after a vaginal delivery, or 1000 milliliters or more after a caesarean section, within the first 24 hours after birth. The good news is, most PPH cases are preventable and treatable if we act fast. In the next few minutes, we will cover 4 critical steps to saving a mother's life. 1. Clinical presentation. 2. Recognition. 3. Resuscitation. 4. Definitive treatment. Because in PPH, minutes matter. Our knowledge and quick action are what stand between bleeding and life. Learning objectives. 1. Define postpartum hemorrhage (PPH) and recognize it early. 2. Identify the major causes using the 4T: tone, trauma, tissue, thrombin. 3. Initiate immediate resuscitation and the WHO motivement bundle. 4. Use uterotonics and tranexamic acid appropriately. 5. Escalate to balloon tamponade, surgery and blood component therapy when required. What is postpartum hemorrhage? 1. PPH is excessive bleeding after childbirth and can deteriorate rapidly. PPH can lead to shock and death within minutes. Recognizing it early gives us time to act before the mother becomes unstable. 2. WHO's 2020 Consolidated Guideline promotes earlier recognition rather than waiting for severe blood loss. Waiting for massive bleeding is too late. Early action based on trends and risk reduces maternal mortality and complications. 3. Act when blood loss reaches about 300 milliliters and abnormal vital signs are present, or when clinically significant bleeding is recognized. The 300 milliliters threshold with abnormal vitals helps us intervene before shock sets in. Clinical judgment is also key when bleeding looks dangerous even if the exact volume is unknown. 4. Use objective quantification of blood loss where possible, including calibrated collection drapes. Estimating blood loss by eye is inaccurate. Measured collection helps us detect PPH earlier and make better treatment decisions. Recognize PPH early. 1. Quantify blood loss rather than relying only on visual estimation. Visual estimation underestimates bleeding by up to 50%. Using calibrated drapes and weighing pads gives us an accurate picture so we can act before it's too late. 2. Monitor pulse, blood pressure, respiratory rate, mental status and urine output. These are early signs of hypovolemia and shock. Changes here often appear before a big drop in blood pressure, so frequent monitoring helps us catch deterioration early. 3. Look for ongoing heavy vaginal bleeding, uterine boginess, retained placenta or genital tract trauma. These are the most common clinical sources of PPH. Identifying the source quickly points us to the right cause and treatment using the 4T. 4. Shock may be eased before hypotension becomes obvious in pregnancy. Pregnant women can lose up to 30% of blood volume and still maintain normal BP due to physiologic changes. Waiting for low BP means we've missed the window for early intervention. The 4T, find the cause. 1. Tone, uterine atony, the commonest cause. This is when the uterus fails to contract after delivery. A floppy uterus cannot compress blood vessels, so it leads to the majority of PPH cases. Uterine massage uterotonics are first line here. 2. Trauma, cervical, vaginal, perineal tears, uterine rupture, inversion. Birth canal injuries cause direct bleeding. If we miss tears or rupture, bleeding continues despite a firm uterus. A thorough inspection here stops the bleeding at the source. 3. Tissue, retained placenta or retained products. Any placental tissue left inside prevents the uterus from contracting fully. This causes persistent bleeding. Manual removal or surgical evacuation is needed to allow the uterus to clamp down. 4. Thrombin, coagulation failure, DIC. This is when the blood cannot clot properly. It may be pre-existing or triggered by massive bleeding. Without addressing the clotting problem, all other treatments will fail, so early lab testing and blood products are key. Immediate response. Call for help. Recognize PPH. Call for help. Resuscitate. Find cause. Stop bleeding. This sequence ensures we stabilize the mother first, then diagnose and treat, so we don't waste time while she is deteriorating. 1. Activate the obstetric hemorrhage emergency response. PPH can worsen in minutes. Activating the emergency team early brings more hands, skills, and resources to the bedside before the mother becomes unstable. 2. Assign roles: airway, anesthesia, obstetric-led, IV access fluids, blood bank, documentation and runner. Clear role assignment prevents confusion and delays. When everyone knows their job, resuscitation and treatment can happen at the same time instead of one after the other. 3. Bring PPH trolley, uterotonics, tranexamic acid, TXA, warming equipment and blood products. Having all essential tools and drugs in one place saves time. Early access to uterotonics, tranexamic acid, TXA, blood, plus preventing hypothermia, improves survival and reduces complications. Resuscitation. ABCDE approach for PPH. A. Airway. Assess and protect the airway, especially if the patient's level of consciousness is reduced. A compromised airway can worsen hypoxia and shock, so securing it early prevents further deterioration. B. Breathing. Give high-flow oxygen if clinically needed. Monitor oxygen saturation and breathing effort. Oxygen supports tissue perfusion when blood loss reduces oxygen carrying capacity and helps prevent organ damage. C. Circulation. Establish 2 large-bore IV lines where possible. Send blood for FBC, group and crossmatch, coagulation profile and fibrinogen as per local protocol. Rapid IV access allows fluid and blood product resuscitation. Early labs guide transfusion and clotting management before results are urgently needed. D. Disability. Check mental status and check blood glucose if indicated. Altered consciousness can be an early sign of hypovolemia or hypoglycemia. Detecting it early guides treatment and monitors brain perfusion. E. Exposure. Quantify blood loss, inspect the perineum and vagina for trauma, and keep the patient warm. Accurate blood loss measurement helps guide treatment. Preventing hypothermia protects clotting function and reduces risk of coagulopathy. Motive treatment bundle for PPH. M. Massage the uterus. Continuous uterine massage stimulates contraction. A contracted uterus compresses the vessels that feed it. This is the fastest first action to reduce bleeding from atony, which causes most PPH. O. Oxytoxic drugs. Give uterotonics immediately. Oxytocin first line, then alternatives if needed. Drugs make the uterus stay firm after massage stops. Without them, bleeding returns quickly and blood loss accelerates. T. Examic acid. Give TXA within 3 hours of birth, as early as possible. TXA stabilizes clots and stops fibrinolysis. Early TXA reduces risk of death from bleeding by up to 30%. Delay costs lives. IVs and resuscitation establish large-bore IV access and begin fluid-blood resuscitation. PPH causes hypovolemic shock. Restoring volume and oxygen delivery protects the brain, kidneys and heart while we stop the source of bleeding. V. Vaginal, genital tract examination. Inspect for retained tissue and trauma, tears, hematoma, rupture. If the uterus is firm but bleeding continues, The cause is trauma or tissue. You cannot treat what you do not find. Examination directs the next intervention. E. Escalate. Bleeding persists. Move to balloon tamponade, compression sutures, arterial embolization, or surgery without delay. When first-line measures fail, waiting increases mortality. Early escalation to advanced care is what saves mothers who do not respond. Step targets a different reason for bleeding. Doing them together closes the gap between recognition and survival. Do all of these in parallel. Do not wait for one step to finish before starting the next. Uterine atony. First-line measures. 1. Uterine massage and assessment of uterine tone. Direct mechanical stimulation causes uterine contraction and reduces bleeding. Ongoing assessment confirms if tone is improving and guides further treatment. 2. Empty the bladder if distended. A full bladder displaces the uterus upward and prevents effective contraction. Emptying it allows the uterus to retract properly and decreases atony. 3. Administer oxytocin according to the current local, WHO-aligned protocol. Oxytocin is the first-line uterotic because it causes rapid, sustained uterine contraction with minimal side effects. Following protocol ensures correct dose and timing for maximum effect. 4. Add other uterotonics according to contraindications and availability. If bleeding continues, second-line agents Misoprostol, methyl ergometrine, or carboprost provide additional contraction. Choice depends on safety and what is available to avoid delays. 5. Look for retained placenta and genital tract trauma simultaneously. Atony can coexist with other causes of PPH. Checking for retained tissue and trauma at the same time prevents missed diagnoses and avoids wasted time while bleeding continues. Uterotonics. Know the contraindications. Choosing the right uterotonic can save a life, but you also need to know when to avoid them. Oxytocin. Role: first-line uterotonic. Key caution: can cause hypotension if given too fast IV. Give it slowly and monitor blood pressure closely. Carboprost PGF2 alpha. Role: very effective for uterine atony when oxytocin is not enough. Key caution: avoid or use with caution in women with asthma because it can cause bronchospasm. Methyl ergometrine, ergometrin. Role: potent uterotonic that keeps the uterus contracted. Key caution: avoid in hypertension and preeclampsia. It can cause a dangerous spike in blood pressure. Misoprostol. Role: good alternative or adjunct when other uterotonics are not available or not enough. Key caution: common side effects include fever, shivering, and gastrointestinal upset like nausea and diarrhea. Always follow your institution's obstetric emergency protocol for the correct dose, route and order of administration. Tranexamic acid (TXA). 1. Give TXA as early as possible once PPH is diagnosed. Benefit is greatest when treatment starts within 3 hours of birth. 2. Standard treatment dose: 1 gram IV. A second 1 gram dose may be given when continues after 30 minutes or restarts within 24 hours, according to guideline criteria. 3. Use TXA as part of the first response bundle, not as a replacement for uterotonics or source control. 4. Check for contraindications such as active, no-embolic disease or other antifibrinolytic contraindications. Trauma. Find and control the source. 1. Inspect the cervix, vagina and perineum if bleeding continues despite a firm uterus. A firm uterus rules out atony. If bleeding persists, the source is likely trauma. Direct visualization is the only way to cervical, vaginal or perineal tears that need repair. Missing them means continued blood loss despite correct uterotonics. 2. Repair significant lacerations promptly with adequate analgesia, anesthesia and good lighting. Unrepaired tears bleed continuously and worsen into hematomas. Proper pain control and visualization allow for precise suturing, which stops bleeding at the source and reduces risk of infection and long-term morbidity. 3. Consider uterine rupture with severe pain, shock, abnormal fetal status before delivery, or a high history. Rupture is life-threatening for both mother and baby. The signs are often subtle until collapse occurs. A high index of suspicion based on pain, hemodynamics, fetal heart changes, or prior uterine surgery allows for immediate surgical intervention and saves lives. 4. Uterine inversion is an emergency. Immediate recognition and prompt replacement are critical. Inversion causes massive hemorrhage and neurogenic shock within minutes. Delay increases mortality. Manual replacement under anesthesia, followed by uterotonics, restore uterine tone and circulation quickly. Seconds matter. Tissue, retained placenta products. 1. Assess whether the placenta is complete and whether the uterus is contracting. Retained products are a common cause of PPH. An incomplete placenta prevents the uterus from clamping down on vessels. Checking completeness and tone helps you identify the source of bleeding early and decide next steps. 2. If placenta is retained, manage according to the clinical situation and local obstetric protocol. Management depends on hemodynamics, amount of bleeding, and whether the placenta is partially separated. Following protocol ensures safe, timely intervention and avoids unnecessary delays or invasive procedures. 3. Manual removal may be required when indicated and should be performed with appropriate analgesia, anesthesia, asepsis and antibiotic policy. Manual removal is painful and carries high risk of infection and uterine trauma. Adequate pain control, sterile technique, and prophylactic antibiotics reduce complications and make the procedure safer for the patient. 4. After removal, reassess uterine tone and ongoing blood loss. Even after tissue is removed, the uterus may remain atonic or bleeding may continue from other causes. Reassessment confirms that the source has been controlled and guides whether additional uterotonics or escalation is needed. Thrombin, coagulopathy. 1. Suspect coagulopathy with persistent diffuse bleeding, oozing from IV sites, abnormal coagulation tests or massive hemorrhage. Coagulopathy often presents as bleeding that doesn't stop despite a contracted uterus and repaired trauma. Diffuse oozing and lab abnormalities signal that clotting factors are depleted. Early recognition allows you to activate the massive transfusion pathway before bleeding becomes uncontrollable. 2. Send FBC, PTINR, APTT, fibrinogen and others according to local massive transfusion protocol. Targeted labs identify which clotting factors are deficient and guide replacement. Fibrinogen drops first in obstetric hemorrhage, so checking it early is critical. Following protocol ensures results are available quickly to direct therapy. 3. Use blood components guided by clinical status, laboratory, viscoelastic testing where available, and local protocol. Blind transfusion can worsen imbalance. Giving plasma, platelets, cryoprecipitate, and RBCs based on labs and clinical need restores hemostasis efficiently and avoids volume overload or unnecessary exposure. Viscoelastic testing, if available, gives real-time guidance. 4. Prevent hypothermia, acidosis and hypocalcemia during major transfusion. The lethal thread impairs clotting enzyme function and platelet activity. Cold, acidic, and low calcium blood makes coagulopathy worse and increases mortality. Active warming, balanced resuscitation, and calcium replacement help maintain effective clotting. Blood transfusion and massive hemorrhage. 1. Activate the local massive obstetric hemorrhage protocol early when bleeding is severe or ongoing. Early activation mobilizes the whole team, blood bank, and resources before the patient decompensates. Waiting until labs can shock wastes critical time. A protocol-driven response improves coordination and survival in massive bleeding. 2. Communicate continuously with the blood bank. Massive hemorrhage requires rapid, repeated delivery of blood products. Continuous communication ensures the right contents are prepared, warmed, and sent without delay, and prevents stockouts or mismatches during resuscitation. 3. Use warmed blood and appropriate blood components according to local protocol and laboratory clinical results. Cold products worsen hypothermia and coagulopathy, giving RBCs, plasma, platelets, and cryoprecipitate in balanced ratios guided by labs and clinical need corrects oxygen delivery and clotting while avoiding dilution or overload. 4. Monitor hemoglobin, platelets, fibrinogen, coagulation, calcium, temperature and acid-base status. Massive transfusion drives the lethal triad of hypothermia, acidosis, and coagulopathy, plus hypocalcemia. Frequent monitoring lets you correct these derangements in real time so that transfused products actually work. Stop bleeding. 5. Do not delay life-saving transfusion while waiting for perfect laboratory confirmation. In severe hemorrhage, clinical judgment outweighs lab values. Delaying transfusion to get perfect results leads to irreversible shock and organ failure. Start with emergency O-negative or group-specific blood if needed, then adjust based on results. If bleeding continues, escalate. Stepwise approach. Uterotonics plus TXA. Examination plus source control. Balloon tamponade. Surgery, embolization. 1. Uterine balloon tamponade is recommended for atony when bleeding not respond to uterotonics or when uterotonics are unavailable, provided appropriate resources and training exist. It compresses the uterine vessels mechanically. This buys time and often stops atonic bleeding when drugs fail, without needing an operating theater immediately. 2. Escalate early rather than repeatedly cycling through ineffective measures. Delay increases blood loss, coagulopathy and mortality. Moving to the next step quickly prevents deterioration and improves outcomes. 3. Definitive surgery may include compression sutures, uterine arch ligation or hysterectomy depending on cause and clinical circumstances. When conservative measures fail, surgical control of bleeding is life-saving. The choice depends on severity, cause, desire for future fertility, and available expertise. Anesthetic considerations in PPH. 1. Prepare for rapid physiological deterioration. Airway, breathing and circulation can change within minutes. Obstetric hemorrhage can lead to sudden hypovolemia and cardiovascular collapse. Anticipating airway compromise and circulatory failure allows immediate intervention before the patient becomes unstable or arrests. 2. Use large bore IV access. Consider arterial monitoring in severe ongoing hemorrhage when feasible. Large bore lines enable rapid fluid and blood product resuscitation. Arterial monitoring provides real-time blood pressure and frequent labs during severe bleeding, guiding resuscitation and anesthetic management accurately. 3. Choose anesthetic technique according to urgency, hemodynamics, coagulation and surgical plan. The decision between regional and general anesthesia depends on stability and bleeding risk. In unstable patients or with coagulopathy, general anesthesia is safer. Matching technique to the clinical picture reduces complications. 4. General anesthesia may be required for severe hemorrhage or operative intervention. Severe PPH often needs surgical control and airway protection. General anesthesia provides airway security, hemodynamic control, and allows for rapid surgical intervention while facilitating massive transfusion. 5. Maintain oxygenation, normata, calcium and acid-base balance. Anticipate difficult airway risk in obstetric patients. Hypothermia, acidosis and hypocalcemia worsen coagulopathy and bleeding. Pregnancy increases airway edema and aspiration risk. Actively managing these factors preserves clotting function and reduces anesthetic morbidity. Practical PPH algorithm. Step 1. Recognize plus quantify. Early detection and accurate blood loss estimation prevent undertreatment. Visual estimates are unreliable. Quantifying bleeding triggers timely activation of the response team and prevents progression to severe hemorrhage. Step 2. Motive bundle. A structured bundle ensures no critical step is missed. Motive covers M. Massage uterus. O. Oxytocin. T. Tranexamic acid. I. IV fluids. V. Vital signs monitoring. E. Escalate. Delivering these together in the first few minutes addresses the most common causes and stabilizes the patient fast. Step 3. 4 teraseconds assessment. Identify the cause to target treatment. The 4 teraseconds are tone, uterine atony, tissue, retained products, trauma, genital tract injury, thrombin, coagulopathy. Treating the specific cause is more effective than non-specific measures and guides next interventions. Step 4. Definitive control. If initial measures fail, move immediately to mechanical or surgical control. This includes balloon tamponade, compression sutures, arterial ligation, embolization, or hysterectomy. Definitive control stops ongoing bleeding and prevents irreversible shock. Bleeding control, asterisk. Yes, right pointing arrow monitor closely plus continue postpartum care. Ongoing monitoring catches secondary bleeding. Continued care supports recovery and prevents complications after stabilization. No right pointing arrow escalate. Balloon, surgery, embolization, transfusion. Persistent bleeding means initial steps were insufficient. Rapid escalation to higher-level interventions and blood products is life-saving and reduces maternal morbidity and mortality. Clinical case. Test yourself. 30-year-old Gravadal 2 Peril 2, 20 minutes after vaginal birth, has ongoing heavy bleeding. Uterus is boggy. Pulse 128 per minute. BP 92/58 of a millimeter of mercury. Estimated loss is increasing. 1. What is your first response? 2. What is the most likely cause? 3. What medications, interventions should occur in parallel? 4. When would you escalate to balloon tamponade or surgery? Answers. 1. What is your first response? Call for help, activate the PPH protocol, and start bimanual uterine massage. Establish large bore IV access and begin fluid resuscitation. Underscore early activation and massage stop bleeding while the team prepares for resuscitation. 2. What is the most likely cause? Uterine atony. Boggy uterus plus immediate postpartum bleeding makes atony the most common cause. 3. What medications, interventions should occur in parallel? Motive bundle. M. Massage uterus. O. Oxytocin 10 IUIM IV then infusion T. Tranexamic acid 1 gram IV within 3 hours I. IV access, fluids, blood products V. Monitor vitals and blood loss E. Evaluate for other causes plus empty bladder. Parallel treatment is atony and prevents shock while ruling out other causes. 4. When would you escalate to balloon tamponade or surgery? If bleeding continues after massage, uterotonics, and TXA, or if hemodynamics worsen. Early escalation prevents coagulopathy and irreversible shock. Take-home messages and key references. 1. PPH is a time-critical emergency. Recognize early and act in parallel. 2. Use quantified blood loss and clinical signs rather than visual estimation alone. 3. Think 4T. Tone, tissue, thrombin. 4. Use the WHO motive bundle. Massage, oxytocin, TXA, IV fluids, vaginal, genital examination, escalation. 5. TXA works best when given early. Do not delay definitive source control. 6. Escalate rapidly to tamponade, surgery, embolization and blood component therapy when bleeding persists. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.